Pharmacology 2, we're on Unit 2, Module 2, Drugs for Respiratory System and Corticosteroids. Here is the generic Pharm subcompetencies. Also on Blackboard is a list of key drugs to know for this module. The main job of the respiratory system is gas exchange. The lungs bring oxygen into the body and removes carbon dioxide. That's a waste product made by cells. There are two main parts of the respiratory system. The first part is the conducting airways, including the nose, the pharynx, the larynx, the trachea, and the bronchi. Their job is ventilation, which means moving air in and out of the lungs. They also warm, moisten, and filter the air. Goblet cells make mucus to trap dust and germs. Tiny hair-like structures are called cilia that move the mucus upward so it can be coughed out. This is called the mucociliary escalator. The second part is the respiratory airways. That includes the bronchioles and the alveoli. This is where gas exchange actually happens. The alveoli are tiny air sacs. Oxygen moves from the alveoli into the blood, and carbon dioxide moves from the blood into the alveoli to be exhaled. Surfactant helps keep the alveoli open so they don't collapse. The right lung has 3 lobes and the left lung has 2 lobes. So breathing is controlled automatically by the brain, but we can also control it voluntarily. When the sympathetic nervous system is activated, the airways widen. This is called bronchodilation. After giving bronchodilators, oxygen saturation should improve if airflow increases. The body protects the lungs through coughing, sneezing, the mucociliary escalator, and alveolar macrophages, which help fight infection. As nurses, we assess respiratory rate and oxygen saturation. We inspect, palpate, sometimes percuss, and auscultate the lungs. If oxygen saturation doesn't improve with treatment, we have to consider problems such as ventilation, diffusion, or perfusion issues. The medications that we'll review are prescribed for both upper and lower respiratory tract disorders. So let's first talk about the upper respiratory tract disorders, such as the common cold, which is a viral infection of the upper respiratory tract. It causes inflammation due to histamine release, leading to congestion, runny nose, sneezing, watery eyes, scratchy throat, and headache. Fever is usually mild or mostly absent. Influenza is also viral but more severe. It includes fever, body aches, fatigue, and respiratory systems. It can lead to serious complications, especially in high-risk patients. Then we have allergic or non-allergic rhinitis. Both involve inflammation of the nasal mucosa. Allergic rhinitis is immune reaction in the body when exposed to an allergen. It's associated with itchy, watery eyes, sneezing, rash. Non-allergic rhinitis are from irritations without that immune defense from the body. So it'll have similar symptoms like congestion and runny nose. Seasonal rhinitis is a type of allergic rhinitis. This is usually caused by seasonal allergens like pollen. Then there's sinusitis, which is inflammation of the sinus cavities, often following an upper respiratory infection, causing facial pressure, pain, and congestion. Pharyngitis is inflammation of the pharynx, viral or bacterial cause, leading to sore throat and sometimes cough. And then finally, laryngitis, which is inflammation of the larynx. It typically causes hoarseness or voice changes and most often happens after an upper respiratory infection. Lower respiratory tract disorders affect the lower respiratory tract, which includes the bronchial tree and the alveoli where gas exchange occurs. Because this region is responsible for oxygen diffusion, the disease process here directly impacts oxygenation and can quickly lead to hypoxia. So let's talk about pneumonia first, which is inflammation of the lung tissue caused by either bacterial or viral infection, or sometimes aspiration. The alveoli fills with fluid or exudate, which impairs gas exchange and decreases oxygen saturation. Bronchitis is inflammation of the bronchial tubes. Acute bronchitis is usually viral in nature, whereas chronic bronchitis, which is part of COPD, involves long-term airway inflammation, swelling, and increased mucus production. There's also bronchiectasis, which is abnormal dilation and destruction of the bronchi, leading to mucus accumulation, chronic infection, and impaired airway clearance. Asthma is an obstructive pulmonary disease. Asthma involves recurrent but reversible bronchospasm and airway inflammation. Airflow improves with bronchodilators. In the younger child, we usually call this reactive airway disease, or RAD. COPD is permanent. It's a non-reversible airway obstruction, mostly caused by smoking or secondhand smoke. It includes emphysema, which destroys alveolar walls, and chronic bronchitis, which causes mucus hypersecretion and airway narrowing. Acute respiratory distress syndrome is a severe inflammatory response following a trauma or sepsis or burns, and causes loss of lung compliance and severe hypoxia. There's also a respiratory distress syndrome, which occurs in the premature neonate who lacks surfactant. It's also called RDS. Without surfactant, alveoli collapse and leads to impaired oxygenation. There's also cystic fibrosis, which isn't pictured here, but it's a hereditary disorder that produces thick secretions. So with cystic fibrosis, the secretions, excessive secretions, obstruct airways, causes chronic infections, and can lead to progressive lung damage. Every medication works differently, but most upper respiratory medications, at least, are for symptom relief. They don't cure the infection, so our job really is to assess and evaluate response before and after administering the med. So we should be assessing for lung sounds, respiratory rate and effort, oxygen saturation, their work of breathing, any presence of cough and secretions, as well as chest expansion symmetry. We might look for other things like clubbing of fingers, skin color, because cyanosis, as we know, indicates hypoxia. If the medication is working, you should see improved O2 sat, hear clearer lung sounds and less wheezing or crackles, decreased dyspnea, less work of breathing, and thinner and easier to clear secretions. If you don't see an improvement, that's a red flag. So non-pharmacological measures are important too when treating respiratory tract disorders. For example, hydration, pushing fluids thins out the secretions. Humidification soothes airways, and avoiding smoke reduces irritation. If it's another allergen, of course, we want to avoid the allergen and any triggers. For COPD, smoking cessation is the most important intervention. For asthma, remember, we have controller medications which are regularly used, as well as rescue or as needed medications to relieve the acute symptoms. If a patient is needing their rescue inhaler frequently, their asthma is not well controlled. Let's start with the pharmacologic class, antitussives. This is a common drug that we administer. So antitussives are cough suppressants, and the key drug to remember, or the prototype, is dextromethorphan. The trade name for this is Robitussin DM. Other drugs in this category are codeine, hydrocodone, and benzonatate. So essentially, especially dextromethorphan, codeine, and hydrocodone work by depressing the cough center in the medulla. So locally, benzonatate works a little differently. These are Tessalon pearls, which are frequently prescribed in the hospital or outpatient. These are local anesthetics that work on the respiratory stretch receptors, which suppresses cough. Now, we need to know that coughing is usually protective. So this is used to control non-productive and exhausting coughs. So if the patient is coughing up mucus, sometimes that is helpful. We want them to cough and spit out to clear the airway. So antitussives are more indicated for the non-productive, exhausting coughs that aren't productive. So it's contraindicated in post-op patients or anyone with excessive secretions. If you suppress a productive cough, those secretions can build up, and that can lead to further problems such as atelectasis or pneumonia. For antitussives like dextromethorphan, codeine, and hydrocodone, we see CNS effects or central nervous system effects that are common, including dizziness, sedation, and drowsiness. So safety is important here, as patients could be have increased risk for falls, and they should not be driving or operating heavy machinery while taking these medications. There's also GI effects of nausea, dry mouth, and constipation, especially with antitussives like opioids, codeine and hydrocodone. So we know those are opioid agonists and controlled substances when they're prescribed alone. Sometimes they're combined in these cough preparations, which make them a Schedule 5, the lowest abuse potential of the controlled substances, but still patients can develop dependence on them, so we don't ignore that risk. So antitussives like dextromethorphan can be available over the counter, so we want to educate our patients about that. One of the most serious adverse effects is respiratory depression. So we know codeine or hydrocodone can cause that, especially. Anytime we give something that suppresses the cough center in the brain, we think about its effect on the respiratory system. And so nursing assessment becomes very critical. So dextromethorphan should not be combined with any MAOIs, as the combination can lead to severe reactions, including hypotension, fever, and even possibly coma. So we have to review the medication history very carefully. We never mix opioids with alcohol, as we know, as the combination can increase risk of a fatal respiratory depression. Robitussin DM or dextromethorphan can be given every 4 to 6 hours typically, or as ordered, to reduce cough. The key prototype for topical nasal decongestants is phenylephrine. There's other common agents, which are oxymetazoline, known by Afrin by trade name, nafazolone, nafazoline, tetrahydrozoline, and xylometazoline. So these are pretty straightforward. They are topical nasal decongestants, meaning they work locally in the nostrils. So the mechanism is pretty straightforward. They cause vasoconstriction, so they decrease blood flow to the upper respiratory tract. When the blood vessels constrict, swelling goes down and secretion production decreases. So that's why patients feel less congested. The indication is simple. It's a symptomatic relief of nasal congestion. These don't usually cure the infection, they just reduce the swelling and they make breathing through the nose easier. Some contraindications, so hypersensitivity, of course, to all drugs. We should take caution with administering. Also, caution in patients that are pregnant and lactating, because these drugs affect blood flow. So they work by vasoconstriction, and there's concern about reduced blood flow to the fetus or potential effects on milk production. A very important adverse reaction to remember is rebound congestion. This leads to passages in the nostrils becoming more congested once the drug wears off after prolonged use. So it's a cycle of overuse. So there's more congestion, and the medication keeps getting used, and it then causes more congestion, so on and so forth. So it's called rebound congestion. So we tell patients very clearly not to exceed 3 to 5 days unless otherwise prescribed by the provider. Local effects include stinging or burning of the nasal mucosa. Systemically, these are topical, so not a lot to be concerned with, but of course some absorption in the body can occur. So you may see dizziness, sedation, or confusion, although it doesn't happen often, especially in children and older adults that are more vulnerable. This may occur. Finally, we want to encourage non-drug measures. So increasing fluids, using humidifiers are always helpful to keep the mucosa moist. And of course, we increase fluids to help thin out the secretions. A different type of decongestion is given orally. So the key drug / prototype for this class of oral decongestants is pseudoephedrine. You might know this as Sudafed. Another agent is phenylephrine. So these are different because they work systemically. They're not topical nasal sprays, which are local in the nasal cavity. Pseudoephedrine and phenylephrine, these oral decongestants work by stimulating alpha adrenergic receptors. These are receptors that are located on blood vessels. So when they're stimulated, they activate the sympathetic nervous system, or the fight or flight response. That, of course, as we know, causes vasoconstriction. So when blood vessels constrict, blood flow to the upper respiratory tract decreases. Swollen mucous membranes shrink, secretion production also decreases, and that's how nasal congestion improves. So in summary, alpha stimulation leads to vasoconstriction, which leads to decreased congestion. So the indications for this drug are to relieve nasal and nasopharyngeal congestion associated with the common cold, influenza, or allergic rhinitis. Hypersensitivity, of course, is a contraindication as well as any other medication. We do not give it if they have a hypersensitivity to it. And we use extreme caution in patients with renal or hepatic impairment, especially in older adults, and also caution during pregnancy and lactation. So patients with hypertension, narrow angle glaucoma, a stroke history or CVA history, diabetes, cardiovascular disease, and hyperthyroidism, we want to avoid administering this to. Also, avoid giving it with MAOI inhibitors. Some common side effects is systemic adrenergic effects, of course, because we know what it does to the adrenergic receptors. So a frequent common effects are dizziness, confusion, and this happens more commonly in children or geriatric patients. We'll sometimes see headache, nausea, vomiting, increased heart rate, or blood pressure. Again, they mimic sympathetic effects. Insomnia may also occur. There's significant interactions with other drugs and a big risk for toxicity when mixed with certain drugs. So even though these are over the counter, it's usually stocked behind the pharmacy counter because there's such a long list of contraindications here, and it does not mix well with other medications. So again, these are usually stocked behind the pharmacy counter even if they're over-the-counter meds. The third type of decongestants is the steroid nasal decongestion, and we have our key drug, which is beclomethasone. Other agents is fluticasone, so you may have heard of Flonase, budesonide, flunisolide, and triamcinolone. This works by decreasing the inflammatory response in the nasal lining, which reduces swelling and secretion. So this is used for allergic rhinitis and relief from chronic upper respiratory irritation and inflammation. Again, hypersensitivity is a contraindication, as well as patients with active infections and those that are pregnant or are lactating. A common and frequent side effect is irritation of the nasal mucosa, dryness in the nasal cavity, and nosebleeds. And of course, we know that's epistaxis in nursing terms. Systemically, this may cause some central nervous system effects like dizziness or headaches, particularly in young children. When combined with other drugs, this could be toxic. It is a local infection, but of course, we know sometimes perhaps there's lesions in the nasal cavity. This can become systemic, although that doesn't occur often. So the difference between this and the topical nasal decongestion is that this can be used in a longer period of time. So it actually may take several days or weeks of regular use to actually reach the full therapeutic effect. So even if it's not working right away, we do educate patients that it may take some time. Antihistamines are a pharmacologic class of drugs that work by blocking the action of histamine at H1 receptor sites. Histamine is released during inflammation and allergic reactions. Histamine increases secretions, causes vasodilation, and can contribute to airway narrowing. So this is why patients develop sneezing, runny nose, watery eyes, and congestion. These medications manage symptoms, so they don't cure infection, they're not antimicrobial, they're indicated for symptom relief of allergic rhinitis or non-allergic rhinitis, the common cold, and influenza. They're divided into first and second generations. So first generation drugs are diphenhydramine, you may know this as Benadryl, and chlormethazine, as well as chlorpheniramine, and also hydroxyzine. These do cross the blood-brain barrier, and they are more sedating and have stronger anticholinergic effects, including dry mouth, urinary retention, blurred vision, and constipation. Sedation can be significant, especially in older adults. Second generation drugs such as loratadine, you might know this as Claritin, cetirizine or Zyrtec, and even I struggle with these pronunciations, fexofenadine or Allegra, do not readily cross the blood-brain barrier. They cause much less sedation and they're generally preferred for daytime use. They're sometimes called non-sedating antihistamines. So when selecting the right medication, we want to consider the age, fall risks, any comorbid conditions, patients with glaucoma or prostate issues. Typically, we don't want to give first-generation antihistamines to. And also if the patient needs to be alert for work or driving, for example. I'm going to reiterate a lot of this again because it's important to differentiate the two classes of antihistamines. So for the first generation drugs, we have central nervous system effects. Drowsiness is the most common. You'll also see sedation, dizziness, delirium, and confusion, especially in children and older adults. So in older adults, sedation and confusion can significantly increase the fall risk, so this is very important to be aware of. Let's talk about the anticholinergic effects. So this means that the drug blocks acetylcholine at the muscarinic receptors in the parasympathetic nervous system. So if acetylcholine normally supports the rest and digest part of the system, blocking it down does the opposite. So everything is going to dry up and slow down. So that's what anticholinergic drugs typically do. Everything dries up and slows down in the body. So you'll see dry mouth, you'll see dry eyes, blurred vision, urinary hesitancy or retention is a big one. Constipation can occur, increased heart rate, thickened respiratory secretions or increased viscosity of their respiratory secretions. So this is a big concern, especially if that's going to cause any airway clearance to become harder. So nausea and vomiting, but again, constipation is pretty particular with older adults especially. We want to use caution in children, especially under 4 years old. We want to avoid the over-the-counter medications. We want to use caution in pregnancy or lactation because they some of the antihistamines can cross the placenta and enter breast milk. So this can potentially cause CNS depression in the infant. So education is very important. Patients should avoid drinking alcohol, especially because this can give them a higher risk of excessive sedation, and because antihistamines may depress the central nerve system, this can also increase the risk for respiratory depression if mixed with alcohol. So like we said, fall risk is big, urinary retention, especially in patients with prostate issues, and if patients need to be alert for driving or work. Let's move on to a different class called expectorants. Guafenicin or Mucinex, being the trade name, is our key drug prototype. So the mechanism is not the same as an antitussive, which depresses the cough center and reduces cough. This actually increases productive cough by thinning secretions, and it decreases their stickiness or their adhesiveness. So it makes it easier to cough up and clear from the airways. So we want those secretions to expel out. So indications for this are those that need symptomatic relief from respiratory conditions, especially associated with dry, non-productive cough, when secretions are starting to form and they need to be mobilized. It's commonly used during the common cold, influenza, and other respiratory disorders to help keep airways patent. So contraindications, hypersensitivity, caution in patients with persistent cough. We want to avoid in children under 4, and we use caution under 6 years old. So side effects and adverse reactions are mild. There's common ones that include dizziness, headache, nausea, and vomiting. Important education topic is increasing oral fluids at the same time. So increasing PO fluids also helps loosen and liquefy secretions in adjunct with this medication. The first type of bronchodilators that we'll discuss is xanthine. The key drug or prototype is theophylline. Other agents are aminophylline and caffeine. They're no longer used as frequently as they once were, and we'll discuss that later. So the mechanism of action is the theophylline having a direct effect on the smooth muscle of the respiratory tract. So this includes the bronchi and blood vessels. It works by affecting calcium movement inside the walls, which ultimately leads to bronchodilation. So the bottom line is that it relaxes bronchial smooth muscle and opens up the airway. Indications for use include symptomatic relief or prevention of bronchial asthma and treatment of bronchospasm associated with COPD. The issue is that these drugs have a narrow therapeutic range. It's very small, around 10 to 20 micrograms per milliliter. That means that there's a small window between a therapeutic dose and a toxic dose. Because of that, they're no longer considered the first choice bronchodilators like they once were. They're rarely used in children due to the adverse effects. And adverse effects are pretty much directly related to toxicity. You'll start to see nausea, vomiting, irritability, tremors, nervousness, insomnia, and even tachyarrhythmias. If levels get too high, and it doesn't take much for it to get too high, it can become dangerous quickly. So we also want to avoid the use of this drug in pregnant women. There are several different drug-drug interactions to be cautious of. Now let's discuss another type of bronchodilator called sympathomimetics. This is one you'll probably commonly see in practice. You may even see it in your household amongst family or friends. And the key prototype for this is albuterol. Other agents are levalbuterol, salmeterol, and formoterol. So that ending in EROL will help you recognize the sympathomimetic bronchodilators. These drugs mimic the sympathetic nervous system, and so they're called the sympathomimetics for that reason. So again, that's the fight or flight response. These stimulate beta-2 receptors directly, and these are located in the bronchial smooth muscles. So when those receptors are stimulated, the bronchi can relax and dilate. The airways will open, airflow improves, dyspnea decreases, and the work of breathing also decreases. So albuterol works very quickly during respiratory distress since it's quickly stimulating those beta-2 receptors. It helps relieve and prevent bronchospasm in asthma and COPD, depending on what type of inhaler they are. So for example, there's the short-acting beta-2 agonists. These are called the SABAs often. So that's albuterol, which are rescue medications used for acute symptoms and exacerbations. It's the drug you give when a patient is actively wheezing or in respiratory distress. So long-acting beta-2 agonists are sometimes, you can hear them being called LABAs. So LABAs, SABAs, that's what they kind of use. And again, these are long-acting LABAs, like salmeterol, for example. These are used for maintenance, long-term, typically like daily administration of it, not for rescue purposes like your SABAs, like your albuterol, which are more for emergencies to prevent the symptoms when they're happening, often prescribed as needed, PRN, for wheezing. So administration is typically through inhalers or nebulizers, which allows the medication to act directly on the airways and quickly. So assessment, again, is critical. The lung status, the breath sounds, respiratory rate, O2 sat, work of breathing, dyspnea. We do expect an improvement to be hopefully assessed after administration. Adverse reactions are related to the sympathetic stimulation, again, fight or flight. So we're seeing increased heart rate, palpitations, nervousness, like how you feel when you're afraid, tremors. These are the side effects, and it's common. These are common side effects, especially of like albuterol. And if it's not extremely tachycardic, these are normal kind of, I guess, common side effects. Not too concerning unless, of course, the patient is extremely tachy. So this happens because beta receptors also exist in the heart, so it may affect those and show those symptoms. Again, if severe tachycardia occurs, of course, the provider should be notified. Contraindications include underlying conditions that may be worsened with the sympathetic stimulation. So certain cardiovascular conditions, for example, if they're already tachycardic, of course, we're not going to try and make them more tachycardic by giving them this medication. Also, use cautiously during pregnancy and lactation. The third type of bronchodilators is called anticholinergics. The key drug prototype here is ipratropium, also known as Atrovent. Other agents include tiotropium, aclinidium, and umeclidinium. These may be combined with other bronchodilators, such as albuterol with ipratropium together is duoneb. So you might see this often used in the hospital, especially. These are commonly used, especially in COPD patients. These drugs block acetylcholine at vagal-mediated receptor sites. So acetylcholine normally causes bronchoconstriction as part of the parasympathetic nervous system. When acetylcholine are blocked, so the opposite will happen. The smooth muscle in the bronchi relaxes and the airway dilates. So this improves airflow and reduces bronchospasm. They act a little slower than the sympathomimetics that we talk about, like albuterol, but they tend to have fewer systemic adverse effects. So that makes them useful in the long-term maintenance therapy use. So indications include symptomatic relief of bronchospasm, especially in COPD. Ipratropium is considered a drug of choice for bronchospasm in COPD patients. It can be used alone again or in combination with the SABAs like albuterol. So typically they're given via inhaler or nebulizer, as the medication also acts directly on the airway. Contraindications, as always, any known allergy or hypersensitivity. We want to use caution in the older adults with renal or hepatic impairment, and also caution during pregnancy as well. So there's fewer adverse effects but you may see some dizziness, headache, and fatigue, possibly some urinary retention as well because of the anticholinergic effect, but we see these a bit less than the sympathomimetics. Now we're going to move away from the bronchodilators and talk about inhaled steroids or glucocorticoids. The key drug here is beclomethasone, and other common agents are budesonide or Palmacort, which you may have heard of, fluticasone, Flovent in the sense of inhaled steroids, so not the Flonase that we talked about earlier, which was the nasal spray. So now we're talking about inhalation. Also, there's cyclesinide and triamcinolone. So these are commonly used in asthma and COPD management as well. They can be combined with bronchodilators, so Flovent or fluticasone with salmeterol is Advair, and this prevents bronchospasms in both asthma or COPD. These drugs decrease airway inflammation, edema, and mucus production. So we know that steroids decrease inflammation. And we've seen that in many different types of medications, whether it's a nose spray or a PO med or an IV med. This one is inhaled. So this one decreases airway inflammation, edema, and mucus production. Asthma is fundamentally an inflammatory disease, so the airway gets swollen and it produces excess mucus and it's narrowed. So this is helping with that inflammation in the airway. It directly, over time, reduces swelling and improves the airway stability. They also do promote beta-adrenergic receptor activity, which improves responsiveness to bronchodilators like albuterol. So often the two together are very effective. In the long term, again, the management of asthma is very common for these drugs. They are controller meds, so maintenance medications that are used often daily, and not PRN in rescue emergencies to prevent symptoms. Also, COPD patients with frequent exacerbations often use this in combination with long-acting bronchodilators, as we mentioned before. They could be used to prescribe in children with reactive airway disease. That's very similar to asthma, as we discussed, so RAD. If the short-acting beta agonists, the SABAs like albuterol, aren't enough. It's important to understand, again, that these are not for emergency use and they don't work immediately. It could take time, just like our nasal spray. It could take typically over 2 to 3 weeks. So they help prevent exacerbations. They do not treat acute asthma attacks. Contraindications are to use caution during pregnancy and lactation because they may cross the placenta or enter human milk. Moving on to the side effects and adverse effects. These are usually local effects, and the most common one, the most common adverse effect that we see is oral candidiasis, also called thrush. It's a fungal infection with white patches that appear in the mouth. Throat irritation can also happen. Common kind of smaller effects that aren't as concerning are sore throat, hoarseness, cough, and dry mouth. So those are kind of common. The provider should be aware if signs of thrush happen in the mouth. They may need treatment for that. So education here is going to be very important to rinse the mouth after using the inhaler and spitting out the water to decrease the chance of a fungal infection. We should use caution in older adults, especially with any other over-the-counter meds or possibly steroids if they're already on steroids. So we need to do a good medical history here. This is usually administered via nebulizer or inhaler. So these are inhaled steroids. Um, Again, they're not rescue meds. They're given long term. We want to educate the patient about rinsing the mouth with water and spitting out, not swallowing. Some people do confuse that. Do not swallow the water after rinsing. So you want to spit out after each dose, rinse the mouth and spit out. And of course, notify the provider if any white patches develop inside of the mouth. Now we'll move on to a different pharmacological class called leukotriene receptor antagonists. The key drug here is montelukast. You may know it as Singulair. There's others, zafirlukast and Ziluton. So remember that leukotrienes are inflammatory chemicals released in asthma. Leukotrienes cause airway swelling, mucus production, and bronchoconstriction. So montelukast works by blocking the leukotriene receptors, which reduces inflammation. It decreases mucus production and it helps prevent bronchospasm. So instead of opening the airway immediately like albuterol, this drug will prevent inflammation from happening in the first place. Indications include long-term management of persistent asthma in both adults and children. They are controller medications used daily long-term to prevent exacerbations. They're especially helpful in children with reactive airway disease whose symptoms aren't fully controlled with the SABAs or the inhaled corticosteroids or a combination of the inhalers that we spoke about previously. Improvement is typically seen in about a week, but that ranges depending on the patient. So contraindications, again, they're not used for acute asthma attacks, and they are controller medications long term. We want to use caution in pregnancy, lactation, and also patients with yep. So adverse effects and side effects. They're generally mild, but commonly we may see some sedation, some dizziness, as well as confusion. Here are some other classes of medications used for respiratory diseases. So mucolytics are used in difficult to expectorate mucus conditions such as cystic fibrosis. So there's a lot of extra mucus in cystic fibrosis. Mucolytics such as acetylcysteine and Dornase alpha thins and loosens thick respiratory secretions to clear airways. It breaks down the chemical structure of mucus. So that's how they thin and loosen thick secretions, by breaking down the chemical structure of mucus for conditions such as cystic fibrosis. Pulmonary surfactants are used in intratracheal emergency drugs for premature neonates with respiratory distress syndrome or RDS. It reduces alveolar surface tension to prevent collapse and allow gas exchange. For pulmonary fibrosis, we may see meds such as nintedanib and pirfenidone. This slows the progression of pulmonary fibrosis. Mast cell stabilizer drugs such as cromolyn prevent release of inflammatory and bronchoconstricting substances in certain airway disorders. These are just some other drugs. Not often seen, but not as common, but you may see them you may see them on occasion. Finally, we're going to end this lecture with our systemic corticosteroids. So this key drug for systemic corticosteroids is prednisone. Other agents we may hear are prednisolone or methylprednisolone. So this is Solumedrol is the common trade name for this. So as we know, steroids decreases inflammation on the lining of the airway. So it will reduce swelling and narrowing of the airway, which facilitates better ventilation. It's used in COPD exacerbations. Just a short course is typically indicated, or asthma management when symptoms aren't controlled by the other controller medications that we discussed, or during severe acute exacerbations. With corticosteroids, we want to be cautious for patients that are pregnant or lactating, as this medication can cross the placenta in human milk. We also want to take caution in older adults and children, especially during puberty. The steroids may affect and alter hormonal balance. So this is a caution that we want to look out for. A common side effect is weight gain and increased appetite. Hyperglycemia is also another side effect. We want to monitor the blood sugars closely, especially if the patient has diabetes. Mood changes may occur and insomnia. A long-term adverse effect is this may cause osteoporosis. So usually systemic steroids, which are given PO or IV, are limited to about 5 to 7 days. Of course, it depends on the diagnosis, but it may be prescribed long-term by the provider, but usually we want to minimize those long-term systemic effects. So they're given usually about 5 to 7 days. The medication has to be tapered, so every day it'll be less and less before the patient stops taking the medication. And this is an education that we have to provide. Also, food should be given when administering this drug to decrease any GI upset for this medication.